Tachyarrhythmias are heart rates greater than 100, regardless of whether it's physiologic or pathologic, if it occurs at rest. Exercise, of course, causes tachycardia that is physiologically and is normal. Our objectives are to understand the mechanisms of the tachyarrhythmias and to understand the diagnosis and management of tachyarrhythmias, to be able to differentiate supraventricular from ventricular tachycardias, which are of greater risk. Some general features of tachyarrhythmias are that they represent rapid heart rhythms of 3 or more complexes of greater than 100 beats per minute frequency. They're usually associated with structural heart disease. Paroxysmal tachycardias are due to re-entry mechanisms where the wave of depolarization cycles a re-entry mechanism through parts of the heart, and they are paroxysmal in that they occur in bursts. Digitalis toxic arrhythmias are a special consideration in that they are due to a triggered mechanism of spontaneous depolarization of cardiac cells. To diagnose tachyarrhythmias, it's essential that we evaluate P waves and QRS morphology to show the origin of the arrhythmia, P waves representing atrial activation and QRS complexes representing ventricular activation. By evaluating the P waves primarily, we can determine the site of origin, the frequency, and the relationship to the normal cardiac rhythm. Another feature of tachycardia is that it may need atrial or esophageal electrocardiograms recordings for identification of P waves. Some further considerations of pathophysiology is that there are basically two mechanisms of tachyarrhythmias, one being abnormal impulse propagation, which we call re-entry, and the other being abnormal impulse formation, which represents enhanced automaticity or triggered activity. On this slide, you can see some of the different causes that can precipitate these different arrhythmias. The re-entry mechanism is the most common mechanism of the two. The first tachyarrhythmia that we are going to consider is premature atrial contractions. They occur in 60% of normal people and usually are innocuous. They are early beats that have an abnormal P wave and a short PR interval as they originate from depolarization of a site within the atria. There is no treatment necessary if they are asymptomatic, but if there is annoying palpitations, the palpitations can be blocked by beta blockers, although this may not stop the premature atrial beats. It only stops the awareness of them. This is an electrocardiogram showing premature atrial contractions. Every second beat is a premature atrial contractions. Notice that they have a different P wave morphology, And if you were able to analyze closely, there's a shorter PR interval. The QRS complexes, which represent ventricular activation, is over normal pathways. This represents what's known as an atrial bigeminal rhythm, where every second beat is a premature atrial beat. Premature beats that originate from the AV node are called AV junctional beats. On the electrocardiogram, the P waves are retrograde and therefore are inverted from their normal morphology. Often there are no P waves preceding what appears to be a normal QRS complex. The beats are premature in the normal sinus rhythm cycle, and no treatment is needed, as these are usually of no great risk. Premature beats that originate from a site in the ventricles that has early depolarization are shown on the electrocardiogram by wide abnormal QRS complexes with what's called fixed coupling, that is the relationship to the normal beat before is a fixed interval with all of the different premature beats. There is also a compensatory pause that is a pause in the pulse as well as on the electrocardiogram following the abnormal premature QRS complex until the next normal cycle begins. We find premature ventricular contractions in 60% of normal people, and the question always is whether or not they represent a condition of risk that needs to be treated. By risk, we're referring to are they at risk of developing ventricular tachycardia or ventricular fibrillation, which are associated with sudden death syndromes. Usually, only if the left ventricular function on an echocardiogram is abnormal do we consider the premature ventricular contractions to be at risk. A condition called ventricular parasystole is when there is a site in the ventricular myocardium that is producing an autonomous rhythm. In this situation, there will be no fixed coupling relationship to normal beats, and there will be regular premature ventricular contraction intervals. Another type of fixed coupling that we refer to sometimes is bigeminy and trigeminy. That is, if the premature beats are occurring in a regular pattern associated with the normal premature beats, so that there is every other beat being a premature ventricular contraction in bigeminy and every third beat being premature ventricular contractions in trigeminy. We also refer to couplets when two premature ventricular contractions occur in series. If there are 3 or more premature ventricular contractions in series with a rate greater than 100 per minute, this constitutes a diagnosis of ventricular tachycardia, which is of more concern. As far as treatment is concerned, no treatment is necessary in the absence of left ventricular dysfunction. If they are symptomatic, beta blockers helps. If there is cardiac disease, the underlying disease is treated appropriately. If they are very high risk, an automatic implantable cardiac defibrillator or use of amiodarone is of some help. By and large, the treatment of these tachycardia rhythms with antiarrhythmic medications only increase the mortality risk. And so therefore, the premature ventricular beats themselves are not usually treated. This is an electrocardiogram showing premature ventricular contractions in a bigeminal fashion. You'll notice that there is a normal-looking beat preceded by a P wave, whereas the subsequent wide abnormal-looking complex has no P wave preceding it, and this represents a ventricular site of origin of this arrhythmia. A persistent rapid heart activity of greater than 100 per minute is the kind of tachycardia we're going to be discussing now. If it looks normal on the electrocardiogram but simply has a rapid heart rate, this is very typical of sinus tachycardia. Sinus tachycardia is usually of non-cardiac origin, is usually physiologic and due to such things as fever, anxiety, exercise, thyrotoxicosis, and so forth. Treatment of sinus tachycardia is usually directed at what the underlying mechanism or cause might be. The next type of tachyarrhythmias that we're going to consider is atrial fibrillation. This is one of the more common problems that physicians face, and so we're going to be looking at it in a little bit more detail as far as treatment and diagnosis and complications. Atrial fibrillation represents spontaneous atrial origin of activity rather than activity beginning in the SA node. The activity is usually 300 to 500 cycles per second originating from the atria in a very irregular fashion. That is, there is no regularity rhythm to this abnormality. So anytime we have an irregular pulse or a totally irregular rhythm on the electrocardiogram, and particularly in the absence of P waves before each QRS complex, we diagnose this as atrial fibrillation. Atrial fibrillation is diagnosed as being paroxysmal if the duration is less than 7 days and terminates spontaneously, or it's determined to be persistent if the duration is greater than 7 days and might last indefinitely unless cardioverted. It's termed permanent if the duration is greater than 7 days and if return to a normal sinus rhythm is not possible. This classification of the different forms of atrial fibrillation is important from the standpoint of etiology as well as treatment. If it's paroxysmal, it may be a single lone episode and never occur again. Time will only tell. If it's paroxysmal atrial fibrillation, it occurs sometimes in normal hearts structurally and is due to non-cardiac causes such as anxiety, exercise, alcohol, hypoxia, metabolic causes, or even postoperatively. If it is persistent atrial fibrillation, this may occur in patients who have underlying heart disease, particularly rheumatic heart disease, and hypertensive cardiovascular disease. Chronic lung disease, atrial septal defect, and non-rheumatic valve disease can also be a cause of persistent atrial fibrillation. If it's permanent atrial fibrillation, the patient will remain in atrial fibrillation for the rest of their life, and treatment will be directed primarily at controlling the heart rate. Some further points as far as treatment of atrial fibrillation. If this is a paroxysmal atrial fibrillation with spontaneous termination of less than 7 days, the treatment focus is on the cause. As you can see here, hypertension or hyperthyroidism particularly. The treatment for paroxysmal atrial fibrillation is class 1C or class 3 antiarrhythmic medications, which you can see at the end of this lecture as an appendix. If the atrial fibrillation is persistent and lasts longer than 7 days, this may require termination with electric cardioversion, and then use class 1C or 3 drugs for prevention of reoccurrence. If this is a permanent condition of atrial fibrillation and the treatment is not directed towards cardioversion, but rather than restoring sinus rhythm, our goal is to control the rapid heart rates. And this is done with digitalization, beta blockers, verapamil, diltiazem, and usually requires also the use of anticoagulants to prevent stroke from embolization. Some clinical considerations of patients with atrial fibrillation is that the symptoms or morbidity is due to increased ventricular rate, hypotension, congestive heart failure, angina, syncope, stroke, from emboli, fatigue, or anxiety. The fibrillatory waves, which we call F waves rather than P waves, occur at 350 to 600 per minute, with a ventricular response that can only respond usually at a rate of 150 to 200 per minute, and is irregular or absolute irregular ventricular activity and pulse. The problem with atrial fibrillation is that it may convert to a slower atrial activity, which we call atrial flutter, and have increased AV conduction so that the ventricular rate becomes more rapid. And we'll discuss atrial fibrillation and flutter subsequently. If the ventricular rate is regular in the presence of an atrial fibrillation, one should always suspect complete AV block. The treatment for patients with atrial fibrillation is prevention of circulatory instability and stroke. And we must always make a decision: will we try to restore a normal sinus rhythm, or is the primary treatment rate control, which we've talked about previously? Consideration of rhythm restoration by cardioversion is possible if on echocardiogram the left atrium is shown to not be enlarged, that is less than 4.5 centimeters in diameter. Another treatment of recurrent atrial fibrillation is ablation, which is passing a catheter into the atria and burning sites, particularly around the pulmonary vein, and we call this ablation. As far as drug treatments with antiarrhythmic medication, is primarily limited to amiodarone and sotalol, whereas rate control medications are beta blockers, calcium channel antagonists, and digoxin. And of course, anticoagulation is needed for prevention of stroke. Patients who have atrial fibrillation have consideration of whether or not they should be anticoagulated for prevention of stroke. The CHADS scoring system is one that is commonly used, in which the presence of congestive heart failure, hypertension, older age, diabetes, previous stroke or TIAs, or vascular disease all have a point system. If the score is greater than 2, then patients should be anticoagulated with either warfarin, which is a vitamin K inhibitor, or non-vitamin K inhibitors such as rivaroxaban or dabigatran. Primarily, warfarin is the drug of choice if there is evidence of a valvular disease associated with the atrial fibrillation. If anticoagulation is needed on a more rapid basis for prevention of stroke, before oral medications can take effect, then IV heparin is the drug that is typically used during this short interim. This slide shows some interesting history of warfarin, which originated primarily as a rat poison and received its name from the Wisconsin Alumni Research Foundation. The use of warfarin for anticoagulation has some problems with management. There are multiple food and drug interactions, particularly food that contain vitamin K. There is also genetic variations in response to this as far as the metabolism of the drug is concerned. And there is a narrow therapeutic window and slow onset of action, requiring 2 to 3 days to achieve prolongation of the prothrombin time to 2 to 3. Due to some of the difficulties in anticoagulation with warfarin, some non-vitamin K inhibiting drugs have been developed for more specific anticoagulation of individual factors. Dabigatran or Pradaxa or rivaroxaban or Xarelta are some of these newer medications that are preferred for anticoagulation in patients who do not have valvular disease. Warfarin still is the primary recommendation for patients with valvular disease. This is an electrocardiogram showing atrial fibrillation. Notice the baseline does not have discrete P waves, but instead it has very rapid undulating fibrillatory waves at a rate of 300 to 600 per minute. Notice also that the ventricular response is totally irregular and occurring at a rate of around 80 per minute average. The QRS complexes, which represent ventricular activation, appear normal. Just to summarize, the medical treatment of patients with atrial fibrillation is directed primarily at correcting the underlying etiology if possible, or cardioversion to a sinus rhythm if possible in patients with recent onset of less than 30 days of atrial fibrillation, or rate control primarily if they have persistent and permanent atrial fibrillation along with anticoagulation, as we have previously discussed. The slide also shows what is termed atrial remodeling, which long-standing atrial fibrillation results in atrial dilation and stretching of the atrial myocardium with remodeling. And this is thought to be one of the mechanisms of the persistent or permanent states of atrial fibrillation. The AFFIRM study gave us most of our information that we have regarding the question of rate control versus restoration of sinus rhythm. And it showed, as we'll see in the subsequent slide, that often rate control is as effective management as rhythm control. Notice on this slide also the arrow showing a clot in the left atrial appendage on a transesophageal echocardiogram. The AFFIRM study showed that the complications of torsade de pointe, cardiac arrest, and the frequency of hospitalization was higher in that group that had an attempt at rhythm control to sinus rhythm, as opposed to those who had only control of the irregular heart rate. The AFFIRM study showed that all-cause mortality of patients with atrial fibrillation is actually better when the goal of treatment is to control the ventricular rate rather than trying to restore a normal sinus rhythm. There are special indications for both methods of management. This slide shows a couple of new developments in the management of patients with atrial fibrillation. That is the Cardia device that on the smartphones can show rhythm strips of atrial fibrillation, and also the Apple Watch, which likewise can show short strips indicating the presence of atrial fibrillation. This is another device that has been developed particularly for exercising patients to show evidence of paroxysmal arrhythmias. We now turn our attention to atrial flutter, which represents atrial activity that has slowed somewhat from atrial fibrillation and is typically around 300 per minute. The ventricular response is typically a ratio of this such as 2 to 1, 3 to 1, or 4 to 1. The two tracings here show on the left atrial flutter with a sawtooth baseline and a 2 to 1 conduction to the ventricles, resulting in a ventricular rate of around 150. On the right is an easier diagnosis to be made, showing the sawtooth flutter waves with a 4 to 1 ratio of conduction with a ventricular rate of 75. This slide shows some of the clinical features of atrial flutter. It's usually associated with organic heart disease such as pericarditis, respiratory failure, and may be seen postoperatively as well. As previously mentioned, the flutter rate is usually 250 to 300 per minute with a fixed conduction into the ventricles of 2 to 1, 3 to 1, 4 to 1, or perhaps even higher. If the ventricular rate is regular and slow, it suggests that there is complete AV block. The treatment of atrial flutter is always electrocardioversion, as patients do not tolerate this type of rhythm well. The drug use for cardioversion is an alternative to electrocardioversion, and we use the drug ibutylide. The cure for atrial flutter, since it has a tendency to reoccur, is ablation of the irritable site in the atria. For prevention and rate control, we use beta blockers, calcium channel antagonists, or digoxin. If the abnormal atrial activity is slower than the atrial flutter and fibrillation rates to rates of less than 250 beats per minute, we speak of this as being atrial tachycardia. There are two types of supraventricular tachycardias. That is what we call PAT, paroxysmal atrial tachycardia, and the other is AV nodal reentrant tachycardia. The latter, the AV nodal reentrant tachycardia, is the most common, occurs predominantly in women, and is manifested by retrograde P waves from the AV node, and is associated with symptoms of palpitations, hypotension, occasionally syncope, rarely acute pulmonary edema, and the treatment is vagal stimulation with carotid sinus massage or Valsalva maneuver. And if these are ineffective, we use adenosine IV, which is almost always 100% effective. For prevention, beta blockers, calcium channel antagonists, and digoxin is used. occasionally, but rarely, pacing and overdriving the rate to a higher rate and capturing with a pacemaker may be necessary to convert this rhythm. If it tends to be recurrent ablation, again, by radio frequency burning of the appropriate site detected on by electrophysiologic studies, is the way of preventing and curing it long term. This is an electrocardiogram showing paroxysmal atrial tachycardia. Notice that the rate is quite rapid, in the range of 200 to 250 per minute, and is totally regular. It's hard to see P waves in the area of the tachycardia because they occur on the previous T wave. And so you have superimposition of the T and a subsequent P wave. Also notice that very characteristic of PAT is the sudden onset and the sudden cessation of this rhythm from sinus mechanisms. Some special considerations in supraventricular tachyarrhythmias is the differential of AV reentrant tachycardia and sinus node reentry as described on this slide. These require electrophysiologic studies for diagnosis and will be dealt with primarily by a subspecialty cardiologist. Another special consideration of supraventricular tachyarrhythmias is the presence of multifocal atrial tachycardia. This can be diagnosed on the electrocardiogram by identification of 3 or more consecutive different P waves with a resultant rate of greater than 100 per minute. It produces an irregular rhythm that has to be differentiated from atrial fibrillation, and 50 to 70% of these patients do develop atrial fibrillation. The primary importance of this arrhythmia is that it is an indication of severe chronic obstructive pulmonary disease or hypokalemia as the primary etiology, and it's associated with respiratory acidosis, and the treatment is to correct the hypoxia and acidosis. This is an electrocardiogram showing multifocal atrial tachycardia. The red arrows indicate the P waves, which have a combined irregular rate of greater than 100 and show multiple morphologies. Pre-excitation syndromes are electrical abnormalities in the heart that predispose to supraventricular tachyarrhythmias and possibly ventricular tachyarrhythmias. The pre-excitation or Wolff-Parkinson-White syndrome is associated with a short PR interval and is due to bypass tracts bypassing the AV node. If these tracts are within the AV node, they are called Langenang-Levine syndrome, whereas if they are bridging the atrial and ventricular chambers with a strip of myocardium, it's called Wolff-Parkinson-White syndrome, and these bridges are called bundle of Kent. The treatment of this condition is to localize these tracts with electrophysiologic studies and ablate the tracts. The presence of these bypass tracts increase the risk of ventricular fibrillation in patients who have atrial fibrillation, because the atrial fibrillation may be conducted through these aberrant tracts directly into the ventricles and produce ventricular fibrillation, which is sudden death. Also, non-paroxysmal junctional tachycardias are a special consideration. These occur at a rate of 70 to 150 beats per minute and is typically caused by digitalis toxicity or inflammatory disease. And the important things regarding these is to diagnose them, because if they are mistakenly cardioverted, it can result in cardiac arrest. The treatment for non-paroxysmal junctional tachycardia is override pacing or treat the underlying cause. This is the typical electrocardiogram of a pre-excitation syndrome of the type called Wolff-Parkinson-White syndrome, which has a bundle of Kent bridging the atria and ventricular areas. You will notice on this that the PR interval is short because it bypasses the AV node, and on the upslope for the QRS complex there is a hump that widens the QRS complex, and this is very typical of Wolff-Parkinson-White syndrome. The short PR interval and the wide QRS complex due to this early depolarization in the QRS complex. This is the electrocardiogram of accelerated junctional rhythm. Notice the red arrows identify the sinus P waves, which are occurring at their normal rhythm. The abnormality is the QRS complexes are occurring early at a faster rate than the P waves due to the pacing site originating from the AV node rather than allowing the P waves to be conducted through the AV node. This is due to an inflammation or irritation or drug toxicity effects on the AV node. This is an electrocardiogram of a case study of a 61-year-old man with chronic atrial fib, congestive heart failure, and hypertension, and he had recently been digitalized. And the electrocardiogram shows evidence of atrial fibrillation, but the rate of the QRS complexes and rhythm is absolutely regular, which it shouldn't be in the presence of atrial fibrillation. There is also high voltage fibrillatory waves, higher than usual, which is a suggestion of left atrial enlargement in lead V1. These findings of atrial fibrillation with AV block, which is the reason for the normal QRS rate, is an indication of digitalis toxicity, and the high voltage as seen in V5 suggests left ventricular hypertrophy. Of course, the difference in atrial mechanism and ventricular mechanism represents a junctional rhythm with what we call AV dissociation. The AV block most likely is due to digitalis toxicity in a patient who has atrial fibrillation. We're now turning our attention to more serious high-risk arrhythmias due to ventricular tachycardia and ventricular fibrillation. We have discussed premature ventricular beats as occurring singly, or if they occur back-to-back, we called it coupling. If 3 or more ventricular ectopic beats occur in a series, we call this ventricular tachycardia. It's considered to be sustained ventricular tachycardia if this rhythm lasts longer than 30 seconds. The cause of ventricular tachycardia usually is ischemia, that is, coronary artery disease with perhaps coronary thrombus formation, prior myocardial infarction or cardiomyopathy, sometimes metabolic abnormalities, drug toxicity, and particularly we're going to be discussing prolonged QT interval as a predisposing factor for ventricular tachycardia. The risk of ventricular tachycardia is that it may change to ventricular fibrillation, and of course this represents sudden death. The other risk is that it may not be hemodynamically stable, and blood pressure may not be supported with this type of rhythm. The ventricular tachycardia can be of one morphology, and we call it monomorphic, or it can be multiple morphologies, and we call it polymorphic, or it can be bidirectional, that is, switch from one morphology to another back and forth. The differential diagnosis of ventricular tachycardia is to differentiate it from supraventricular tachycardia that has wide QRS complexes that we call aberrant conduction. Ventricular tachycardia, since it is a type of AV dissociation where the atrial and ventricular contractions may be asynchronous, may be associated with Canon A waves in the neck veins and have varying intensity of the first heart sound. And on the QRS morphology, it's widened, that is greater than 0.14 seconds. There are also some characteristic electrocardiographic abnormalities, that is a superior oriented QRS axis with right bundle branch block, and a QRS that is inconsistent and cannot be explained by bundle branch block. This is a very high risk condition, and the treatment is urgent with cardioversion, electrocardioversion, and prevented with treatment with beta blockers, verapamil, amiodarone, and perhaps other antiarrhythmics medications. Sometimes override pacing, that is pacing at a more rapid rate and then slowing, is required. This is an electrocardiogram showing ventricular tachycardia. Every beat is due to an ectopic ventricular beat and has a wide morphology, and as shown in lead 2, may vary in morphology and might even be bidirectional. No P waves can be identified before any of the QRS complexes. The rate typically is in the range of 150 to 250 beats per minute. This is an electrocardiogram and case study showing the difficulty in differentiating between ventricular tachycardia and supraventricular tachycardia with right bundle branch block. Either diagnosis on the basis of this information is a possibility. The QT interval represents the electrical systolic period, And occasionally there may be congenital prolongation of the QT interval, or it may be associated with hypokalemia or hypomagnesemia or quinidine medications. The prolongation of the QT interval, rather than whether it be acquired or congenital, represents a risk factor for polymorphic ventricular tachycardia. And the treatment of this is with beta blocker therapy, sometimes magnesium replacement, and sympathectomy may be necessary, as this is a very high risk condition. Polymorphic ventricular tachycardia is when there is multiple QRS morphologies, and the QT interval may be normal in this situation. And the treatment for this to prevent ventricular tachycardia is class 1 or class 3 antiarrhythmic agents pharmacologically. This electrocardiogram illustrates a prolonged QT interval, as you can see from the purple arrows, and carries a risk of ventricular tachycardia. This electrocardiogram shows what might result from patients with prolonged QT interval. Torsade de pointe, which means to twist or turn around a point, it describes the electrocardiogram here, which is polymorphic ventricular tachycardia. This may not be a rhythm that can support blood pressure and needs to be treated much the same as ventricular fibrillation. This electrocardiogram illustrates polymorphic ventricular tachycardia developing in a patient who does not have prolonged QT interval. This arrhythmia was recorded on a 24-hour Holter monitor tracing, and the question is, does it show torsade de pointe, ventricular fibrillation, or ventricular tachycardia? Probably any of these three could be accurate. This continuous recording shows a little Lager who was struck by a pitched ball in the chest, collapsed unconscious, and fortunately had access to a defibrillator to correct what otherwise was ventricular fibrillation. This is known as commotio cordis when it's due to a concussion of the chest. This electrocardiogram shows the difficulties sometimes in making a diagnosis from the electrocardiogram, which suggests inferior myocardial infarction when it actually was due to intracranial hemorrhage in a 19-year-old that was struck in the temple with a brick. Some other conditions associated with tachyarrhythmias is illustrated on this slide. Accelerated idioventricular tachycardia is also known as slow VTAC. It appears to be wide QRS complexes, ventricular in origin, but occurring at a rate of 80 to 120 per minute. The important thing is to recognize that this occurs in patients who has been treated for acute myocardial infarction, and it represents an arrhythmia due to reperfusion of the coronary artery, and no treatment is indicated in this. Ventricular flutter and fibrillation, actually flutter should be considered fibrillation, is most often due to ischemia and antiarrhythmic drugs themselves. It may occur, as we mentioned previously, from Wolff-Parkinson-White syndrome with atrial fibrillation being conducted into the ventricles. Electrocution is also a cause of ventricular fibrillation. Also, deterioration of ventricular tachycardia is a mechanism. The treatment is always defibrillation with cardiopulmonary assist. The genetic syndromes we've talked about, congenital long QT interval, but there is also other cardiomyopathies that are associated with arrhythmias, such as arrhythmiogenic right ventricular dysplasia, hypertrophic obstructive cardiomyopathy, catecholamine-related cardiomyopathy, and more recently we've heard about the Brugada syndrome, in which there is a pseudo right bundle branch block and elevated ST segment and inverted T waves in leads V1 through 3. And it is high risk for sudden death and ventricular arrhythmias. This is an electrocardiogram showing runs of ventricular beats occurring at a rate of around 75 to 80 per minute. And it represents what we previously described as slow ventricular tachycardia. This is considered technically to be a type of parasystole with a focus in the ventricles producing an autonomous rhythm. This, as previously discussed, is often due to reperfusion of an obstructed coronary artery and does not require treatment. This is a slide summarizing sudden arrhythmic death syndrome, or SAD. The arrhythmia is almost always ventricular fibrillation, and you can see that it occurs in these different types of cardiomyopathies. This slide illustrates the features of arrhythmogenic right ventricular dysplasia, which is a non-ischemic cardiomyopathy of genetic origin. The treatment of this, other than cardiac transplantation, is implantation of an implantable cardiac defibrillator. This is a typical arrhythmia of arrhythmogenic right ventricular dysplasia showing ventricular tachycardia. This is a typical case of Brugada syndrome with the classic electrocardiogram, and the appropriate treatment for this is an automatic implantable cardiac defibrillator. This is another syndrome associated with sudden death. It's called the SUND syndrome, sudden unexpected nocturnal death, and it occurs primarily in Southeast Asian populations. This electrocardiographic tracing shows evidence of a very rapid type of heart rhythm of over 300 beats per minute. The QRS complexes are widened and abnormal, and this represents ventricular ectopy in a rate of atrial flutter or fibrillation. We generally consider flutter and fibrillation together, as not being two separate entities. The actual ventricular fibrillation can be seen on a echocardiogram, looking at the ventricles quivering, as opposed to asystole from cardiac arrest, in which there is no movement of any parts of the heart. Treatment of tachyarrhythmias have multiple possibilities. The first is drugs, and the primary drug effective, particularly in life-threatening arrhythmias, is amiodarone. Electrical pacemakers or cardioversion or defibrillation, or implantable cardiac defibrillators are all possible electrical treatments, as well as resynchronized pacing in patients who have heart failure and cardiomyopathy. Ablative treatment, that is burning of the spot originating the abnormal impulses, may be a consideration in Wolff-Parkinson-White syndrome, in particular atrial fibrillation and atrial flutter, as well as AV nodal reentrant supraventricular tachycardia. Surgical treatments of ventricular aneurysmectomy may be helpful in patients with ventricular life-threatening arrhythmias. Coronary arterial bypass grafting may be helpful in the ischemic conditions, and certainly a cardiac transplantation must be considered a possibility in these more severe conditions. This slide illustrates the use of implantable cardiac defibrillator, which discharges in the presence of ventricular fibrillation and conducts an impulse from the electrode in the right ventricle to the case of the battery case of the implanted defibrillator. This and the subsequent slides are presented to show you the mechanisms of action of different pharmacologic agents and the classification of the antiarrhythmic drugs.